Добрый день, уважаемые коллеги. Мы начинаем сессию. Идет синхронный перевод, да? Там для коллег. Профилактической кардиологии 2020.
Yes, very well. Thank you.
Первый доклад у нас в записи, однако профессор Томаш Гузик в режиме ожидания, чтобы ответить на наши вопросы. Как повлиять на воспаление при артериальной гипертонии? Пожалуйста, включаем презентацию.
Ladies and gentlemen, good afternoon. Thank you very much for an opportunity to present during this important meeting. And it's a huge pity I cannot be present in person in Moscow. I hope we will meet again soon. I was asked to talk about therapeutic targeting of inflammation in the context of a disease that is not maybe most obviously associated with inflammation, that is hypertension. I focus on hypertension because it remains a major global factor for mortality, in spite of the fact that we have a number of different therapeutic strategies that we can utilize. Interestingly, Eurospire studies show that in spite of use and potential use of numerous medications, blood pressure remains uncontrolled in majority of patients. Of course, you may say this is partially related to poor compliance, but I would argue that it might also indicate that we do not fully understand the genesis of the disease, and maybe there are some other mechanisms that we could target therapeutically. Our understanding of pathogenesis of hypertension is quite complex. It involves the role of central nervous system, kidneys, vasculature, and the heart. In this talk, I will try to convince you that immune system and inflammation is very important in both regulation of blood pressure in hypertensive individuals, as well as in development of target organ damage. So what evidence do we have to support the idea that inflammation actually is part of hypertensive pathology? When we look at hypertensive vessels, and in this case we looked at aorta and arteries, so small arteries of mice in which we evoked hypertension, we can see that there are three different systems changed in the transcriptomic analysis. This includes developmental pathways, apoptosis, but importantly, immune system immunoregulation is an important element that's changed during hypertension in the blood vessel itself. This is accompanied by a significant infiltration of immune cells into the vessel wall. We can see that hypertensive animals show increased presence of T cells, macrophages, as well as antigen-presenting cells, dendritic cells in the vessel wall space. And this can be also imaged histologically. You can see sea of red and green cells and dendritic cells in the hypertensive aorta, while in the normotensive animal, there is much less. They localize mainly in perivascular space. But the question is, what do they do? Are they just a mere consequence that pushes T cells into the space, or are they actually participating in pathogenesis of the disease? A number of years ago, working with David Harrison at Emory University in Atlanta, we infused angiotensin II in mice lacking T and B lymphocytes. And we were surprised to find that blood pressure did not increase in these animals as much as in control mice. T-cell reconstitution recovered these phenotypes, and this was associated with regulation of oxidative stress and endothelial function measured as ability of blood vessels to relax, which is corresponding to ability of the vessel to produce nitric oxide. So we could see in these experimental studies that T cells are actually functionally important in the development of hypertension. These were surprising findings that were then confirmed by a large number of various studies in different models. We can see that in other models of immunosuppression, such as skin mouse, we have similar protection from the development of severe hypertension, and more recently, RAG1 knockout rat by decreased development of blood pressure, increase in different models, in this case linked to the kidney pathology. So immune cells seem to be infiltrating perivascular space. They release cytokines because these are the ways immune cells work on blood vessel wall and on other cells that then can cause endothelial dysfunction with loss of nitric oxide biology and increase of the amount of superoxide. The big question that arises is this phenomenon also present in humans? Of course, addressing this in humans is much more challenging. However, we took up several different approaches that I will share with you. Firstly, we looked at the presence of circulating activated immune cells in hypertension. That hypertension was associated with increased number of memory cells. These memory cells were accumulating, particularly within the 8, but also to some extent 4 compartment. At the same time, we looked at cytokine production. As I mentioned, cytokine tool immune cells affect biology. And we could see that hypertensive pathology was associated with very significant increases of release of number of cytokines such as interferon gamma or interleukin 17. We even followed up these patients later to ensure that they did not develop subsequently rheumatoid arthritis or some other disease associated with immune system function, but so far they didn't. Of course, this is observational. That's why to address this in a more epidemiological point, we have actually used a very large population of UK biobank, in which we studied almost 400,000 people in whom white blood cell counts were available, as well as blood pressure. We compared these, and we found, interestingly, that with increasing numbers of circulating immune cells, and this was observed in lymphocytes, monocytes, and neutrophils, we could see increasing blood pressure. But again, this is observational. More lymphocytes or more monocytes or more neutrophils means more higher blood pressure, but it might be just a result of pathology. Therefore, we decided to use a technique called Mendelian randomization. It is a method that uses the fact that at birth we are given predisposition to certain diseases, such as blood pressure, such as, for example, high lymphocytes, or such as blood pressure, and this we will call exposure. If we want to test if this exposure is associated with disease, and in our case this will be hypertension, then we can perform statistical analysis using Mendelian randomization techniques. Mendelian randomization has several sort of assumptions. Firstly, that both of these are not affected by unobserved confounders that might be associated or not associated in that case with the genetic tool or predisposition used, and there is no independent association between the studied genetic tool and the disease. So, as I said, in our case, exposure will be immune cells and disease, blood pressure. We have identified a number of single nucleotide polymorphisms associated with levels of monocytes, lymphocytes, eosinophils, basophils, neutrophils. For each of these cell types, we identified a different set of polymorphisms that we will call a genetic tool. When performing the analysis, and this is a heat map, so the redder the little square, the more association was observed. We could see that lymphocytes and to some extent eosinophils were particularly strongly associated and showing causal association with blood pressure in UK biobank population. So interestingly, in a very large epidemiological study, we could see that lymphocytes and eosinophils are actually potentially causal in hypertension in humans. But as we mentioned, it is possible that actually blood pressure might also be affecting immune cells. And we also observed that actually the relationship between neutrophils or monocytes was to some extent greater with blood pressure than lymphocytes itself. And they did not show up so strongly on our initial Mendelian randomization analysis. Therefore, we used GWAS studies for hypertension to identify 883 independent polymorphisms as a genetic tool showing risk of exposure to blood pressure. And we looked opposite way. We looked at their effect on immune cells. Interestingly, in this analysis, lymphocytes did not show significant association at all, showing that they are only one way associated with hypertension or increased blood pressure, while neutrophils and monocytes and eosinophils were all affected by blood pressure. So in summary, we found that lymphocytes are causally linked to blood pressure, while blood pressure affects the numbers of monocytes, neutrophils, and eosinophils in blood. So this is interesting, but can we use this therapeutically? Can we actually apply this knowledge in introducing treatments? Of course, you will say, well, using the immune suppressive therapies may be dangerous, but we do use them for diseases such as psoriasis, which is a skin disease. So I could imagine that if we developed a good immune-targeted intervention, it would be permissible to prevent death in humans. Obvious candidate for addressing this question is CANTOS trial, and we collaborated with Paul Ridker and Alex Rothman in a project where we analyzed the effect of canakinumab in different doses used in the trial on blood pressure in the patients. To our surprise or sadness to some extent, we did not see effect of canakinumab, so interleukin-1 beta targeting on blood pressure in the patient population of CANTOS trial. When we looked, however, a little bit more deeply into this trial, we could see that actually only top quartile of patients, only 25% of patients showed actual values of hypertension. The remaining patients were not hypertensive. Interestingly, the clinical effects of canakinumab on MACE, myocardial infarction, coronary revascularization, as well as on death, were most visible and actually significant in quartile 4 of CANTOS population. That even if IL-1 beta is not affecting blood pressure, it can actually help us prevent vascular consequences. But, you know, you would say, well, CANTOS trial has shown us to some extent that it will be difficult to convince you, cardiologists, to actually start using immunosuppressive therapies in cardiovascular disease very widely because of costs and other maybe factors. That's why we started thinking, is there a way that we could identify systemic inflammatory disease that we could target and see if this could help us in better control of blood pressure? So we asked the question, what's the most common source of systemic inflammation in humans? And I would like you to now have a look at this picture and think, what do you think? Well, I can tell you that one of these factors is prevalence is about 50 to 60% in moderate form of disease in patients above 65. This is a pretty common disease, isn't it? And this is actually periodontitis, and it's a severe inflammation in the gums. So in order to address this, we first decided to look at all the observational studies available to try to link, understand if there is a link between periodontitis and hypertension. And indeed, as you can see from this systematic review and meta-analysis we published last year, you can see that there is a significant association between hypertension and periodontitis. How to test this in patient populations? Of course, we can again use Mendelian randomization, as well as we could use randomized clinical trial in order to address the question, is the improvement of periodontal status leading to improvement of blood pressure control in hypertensive patients? We used these two in a recent study that we published in European Heart Journal. Looking at the genetic evidence, you can see, similarly to the one that I described, we used 4 polymorphisms that are predisposing people to have high risk of periodontitis, and you can see that they are associated with systolic and diastolic blood pressure very significantly, using a number of different techniques of Mendelian randomization. We always try to use various techniques because Mendelian randomization has certain assumptions and risks, and we try to avoid confounding factors as much as we can. In this case, what is also important is that polymorphisms increasing risk of periodontitis are increasing systolic blood pressure, and the ones that are associated with decreased risk of periodontitis are associated with decreased risk of higher blood pressure. So this is, again, quite convincing. But as while in white blood cell study, we used very large number of polymorphisms, which creates a very strong genetic tool. In this case, we use only 4 polymorphisms, so we thought that using a randomized study to further address this question will be very important. So you can see we randomized patients to either intensive periodontal treatment or classical periodontal treatment, that is just cleaning the teeth and observing the patient for 2 months, and we perform ambulatory blood pressure monitoring before the treatment and after the treatment. You can see that there was a very significant difference in blood pressure, ambulatory blood pressure, upon intensive periodontal therapy, but not upon conventional periodontal therapy, leading to a difference in change, which is quite significant, but interestingly, quite comparable to reported by a smaller study using office blood pressure as an endpoint. Similar reduction of blood pressure by intensive periodontal therapy was observed in intensive periodontal treatment group in relation to diastolic blood pressure. When we were doing this study, we used a number of secondary endpoints, and these included endothelial function, and we found that already after 2 months after intensive periodontal therapy, we observed significant improvement of flow-mediated dilation, so endothelial function in patients, which confirms findings in atherosclerotic groups reported earlier by Tonetti in England Journal paper. The nitroglycerin, so controlled dilatation, did not differ in these patients, but what was most interesting is that we also very carefully screened and followed the periodontal status in these patients. So we looked at the improvement of local inflammation in the oral cavity. And you can see that the degree of improvement, delta PPD, which is a change in periodontal pocket depth, an index of periodontal inflammation. So improvement in this index was significantly correlated with improvement of blood pressure, again emphasizing that inflammation is taking at least partially a partial responsibility for the improvement in blood pressure control that we observe in patients. But as we are very interested in immune and inflammatory mechanisms, we performed a wide screening for various immune cells in the vessels, in the blood of patients during the study. And among many markers that we looked at, we identified only 2 being very significantly changed. And these represented immunosenescent, activated CD8 T cells. You can see this is represented by T cells bearing marker called CD38. These are activated cells that go down after the intensive periodontal therapy in peripheral blood, and immunosenescent cells that change significantly as well. This is interesting because especially the immunosenescent cells had been linked before by a nice Korean study to pathogenesis of hypertension in humans. So in summary, I hope I have convinced you that immune mechanisms do play a role in hypertension, and that maybe we have an opportunity in that regard to try to understand in deeper this involvement, as well as potential therapeutic implications of this. Maybe if we identify very specific immune focused or immune cell focused therapeutic strategies, we could have novel therapies improving control of hypertension in large populations. At the moment, I think the most permissible approaches might be non-pharmacological, which could include ensuring that your hypertensive patients have very good oral hygiene and oral health. Thank you very much for your attention.
Большое спасибо, профессор Гузик. Мы рады видеть вас. Прекрасная лекция, очень актуальная. Есть ли вопросы в аудитории? У меня есть один вопрос, но вначале я хочу спросить, может быть, кто-то из зала готов задать. Хорошо. Вот вы упомянули, что иммуносупрессивная кардиология терапия не оправдана у кардиологических больных из-за стоимости, ну и ряда причин. Но в период пандемии мы вынуждены были вводить иммуносупрессивные препараты, да, ингибиторы интерлейкина И6, И1, мы даже канакинумаб вводили нашим пациентам. И, конечно, большая часть из них имела в том числе и гипертонию. Вот как вы думаете, в свете ваших данных, вашего доклада, может быть, вы уже ведете такие работы, о влиянии вынужденного применения иммуносупрессивной терапии при COVID-19 на последующее течение сердечно-сосудистых заболеваний, включая артериальную гипертонию, но, может быть, и атеросклеротические?
I don't hear the translation, но я говорю несколько по-русски, тогда я понял только что вы сказали. But maybe I will answer in English if that's okay, because I don't hear the interpreter. But what I understand is that in COVID-19, we are actually seeing a number of key molecules that are upregulated to a similar fashion to the upregulation or dysfunction of immune system we see in hypertension. And this could in fact explain why, or could be at least partial explanation, why hypertensive patients have a higher risk of a more severe course of disease, as we have quite convincing epidemiological evidence about hypertension itself being increasing risk. At the same time, as we know, ACE inhibitors and ARBs are actually reducing risk of severe COVID, and in spite of the initial worries that it would be otherwise. And again, they are also acting as potentially anti-inflammatory treatments, because we know from patients with rheumatoid arthritis, with ankylosing spondylitis, that patients receiving angiotensin, for example, receptor blockers, improve their rheumatological status as well. So I think these aspects are supportive to this theory. Of course, there is always a question of certain immunosuppressive therapies actually increasing blood pressure, and this we always have to pay attention to, and it's usually mediated by direct effects of these therapies on renal function, on the kidneys, and on certain transporters that's quite well defined, for example, in relation to cyclosporin. I hope it answers the question. Я думаю, я понял, но вы можете...
I have a question, if it's possible.
Dear colleague, dear Tom, dear Aldo, I want to welcome you. It's not a question, it's just welcome, words of welcome, and
Thanks a lot.
And also
Nana.
Words of gratitude for joining us in this difficult time, and taking into account your schedule, which is very busy. Many thanks for us in this distant format.
Thank you.
Thank you.
My co-chair will continue.
I have a question for Thomas. Thank you very much, Nana, for the
Отлично,
introduction.
спасибо большое, профессор Гузик. Мы двигаемся дальше. Следующий доклад представит Альдо Маккиони, директор исследовательского центра Флоренции. Сердечная недостаточность сегодня, новые методы и текущая практика.
Very brief question.
Добро пожаловать.
You mentioned canakinumab as a potential treatment in patients with hypertension. What about colchicine, that in terms of cost is nothing, and showed very impressive results of also very recently in the ESC Congress?
Exactly, and we are actually now aiming to perform similar analysis in the colchicine patients. We were trying to get in touch with some of the trialists with colchicine to try to introduce ambulatory blood pressure during a study.
Yeah.
Because the big problem of the trials is the measurement of blood pressure is not always fully standardized, because it's not an endpoint. So this is a strong weakness of this kind of sub-analysis. But I think that colchicine and maybe some other cheaper and maybe also safer solutions are the future, apart from the non-pharmacological approaches we proposed. I agree with you completely. Thank you very much. And спасибо большое to Nana and спасибо все.
Хорошо, спасибо. Профессор Магиони, мы слушаем вас. У нас запись.
Good afternoon, dear colleagues. My task today is to discuss with you the novel treatments and the current practice in patients with heart failure. This slide shows my disclosure, or even better, the disclosure of the institution for which I work, that are the research center of the Italian Association of Hospital Cardiologists, and I am also the scientific coordinator of the Euro-Observational Program of the ESC. The contents of my presentation are reported here. I will discuss shortly the evidence-based treatment for the patient with chronic heart failure and reduced ejection fraction, the new pharmacological treatments for these patients, and what is available for patients with chronic heart failure but with preserved ejection fraction, and finally, the new treatments for the comorbidities of patients with heart failure. Let's start with the evidence-based treatment. Everybody probably knows the algorithm of the treatment of heart failure and reduced ejection fraction written by the ESC in its guidelines of 2016. As you know, all patients should be treated with a blocker of the renin-angiotensin system, either ACE inhibitor or ARB, and if they are still symptomatic and with an ejection fraction equal or lower than 35%, they should be treated with an MRA as well. Then, if the patients are still symptomatic and in sinus rhythm and with an heart rate equal or more than 70 beats per minute, the patient should be treated with ivabradine. And more recently, the recommendation is to use or to replace an ACE on an ARB with sacubitril valsartan. These are the pharmacological treatments strongly recommended by the ESC guidelines. But what happens in clinical practice? This study was conducted some years ago using a registry directed by the ESC with the Euro-Observational Research Program. As you can see in the European countries, more or less all the patients are treated with ACE inhibitor and ARBs. Just 8% of them do not receive one of these drugs. The situation is very similar for beta blockers. Just 7% of the patients included in the registry were not receiving a beta blocker, and 1/3 of the patients of the registry were not receiving a mineralocorticoid antagonist. So in clinical practice, the adherence to the guidelines, at least in qualitative terms, are sufficiently good, but the problem is related to the dosages. As you can see, less than 30% of the patients treated with ACE inhibitor, ARB, beta blocker, or MRA are receiving the appropriate dosages recommended by the guidelines. So if there is something to improve in the adherence of the guidelines, is to work in trying to up-titrate the patient to a maximal dosage recommended to the guideline, of course, if it is possible due to the condition of the patient. The trial that changed the practice was the Paradigm HF trial, published in 2014. The results are very well known. Using sacubitril valsartan in comparison with enalapril, it was possible to reduce the combined endpoint of cardiovascular death and hospitalization for heart failure of 20%, and the difference, as you can see, is highly statistically significant. The result is surely not novel, but there are some novel evidences regarding the use of sacubitril/valsartan. First of all, the possibility to use earlier than in the paradigm study this treatment. Some data regarding the effects of sacubitril/valsartan on arrhythmias, some data on the effects on remodeling processes, and data on the effects on mitral regurgitation. Starting from the Pioneer study that tested sacubitril/valsartan in patients recently admitted for acute heart failure, then stabilized during the hospital stay, but before discharge, the patient were randomized to sacubitril/valsartan versus enalapril, and the efficacy endpoint was a measure of biomarkers, and there was, of course, a very important safety endpoint. The results are reported here. The patient allocated to sacubitril/valsartan showed a significant reduction of BNP with respect to the patient allocated to enalapril, but even more important, the expected side effects of the drug were not different between sacubitril/valsartan and enalapril. As you can see, worsening renal function was nominally lower in the sacubitril/valsartan arm. Hyperkalemia was the same. Symptomatic hypotension was a little bit higher in sacubitril/valsartan group, but not statistically significant. And angioedema occurred less frequently in the sacubitril/valsartan arm. This data on safety can assure that you can start sacubitril/valsartan even earlier than the patient is really stable, as in paradigm. You can start the treatment during the hospital stay, just before discharge, when the patient is stabilized. With respect to arrhythmias, it was very important to see that the total mortality reduced in paradigm trial by sacubitril/valsartan was split in this study in the cause of death, sudden death, and the cause of death due to worsening heart failure. And as you can see, the drug worked very well on both causes of death, reducing significantly sudden death and also the death due to worsening heart failure. The result of sudden death was quite impressive, because as you can see, the Kaplan-Meier curve started to diverge very early and continued to diverge during the whole period of the trial. There is a study trying to explain this effect on arrhythmias. In this study, 120 patients with heart failure and reduced ejection fraction and with an implanted ICD were studied comparing an ACE inhibitor and the sacubitril/valsartan. And sacubitril/valsartan reduced, with respect to the ACE inhibitor, the non-sustained episode of ventricular tachycardia, and also the sustained episode of ventricular tachycardia and the appropriate shocks of the ICD, and also the premature ventricular contraction per hour were significantly reduced with sacubitril/valsartan with respect to ACE. With respect to the cardiac remodeling, the study shows that using sacubitril/valsartan, there was a clear increase in ejection fraction at 6 months, 5 points, at 12 months, 9 points, and even more interesting, 1 out of 4 of the patients treated with sacubitril/valsartan showed an increase in ejection fraction at 12 months of equal or more than 14%. So a very relevant, a clinically relevant increase of ejection fraction, and the volume, left ventricular and diastolic and then systolic, were also significantly reduced. This paper showed also that in patients with both reduction of neurohormones and volume, the outcome was very favorable, while in patients without a reduction under the median of BNP and under the median of the left ventricular systolic volume had the worst outcome. With respect to mitral regurgitation, 118 patients were randomized to sacubitril valsartan versus valsartan alone, and there was, with ARNI, a greater decrease in the effective regurgitant orifice area and also in the regurgitant volume. So there are some novelties for a relatively new treatment that is sacubitril valsartan, but there are some more novelties for new drugs. First of all, the class of SGLT2 inhibitors. You know that these drugs were developed for treating diabetes, but in trials with diabetes, it appeared that this drug can work also in patients with heart failure without diabetes, and the trial was planned in this sense. Patients with heart failure and reduced ejection fraction were randomized to DAPA-HF trial, testing dapagliflozin versus placebo, and this is the main result. The primary outcome of the study, that was cardiovascular death, hospitalization for heart failure, or an urgent heart failure visit, was significantly reduced in the patient allocated to dapagliflozin with respect to the patient allocated to placebo. The reduction was 26%, highly statistically significant. And as you can see also, the absolute value of this treatment, the NNT, was just 21. Looking at the different components of the endpoint, the drug has a favorable effect on both worsening heart failure event and cardiovascular death. But even more important was the analysis, the subgroup analysis, showing the results in terms of patients with diabetes and no diabetes. As you can see, the effects were very similar. So this drug, developed specifically for diabetes, resulted to be very efficient, very effective, also in patients without diabetes. In front of a favorable figure in terms of adverse event of interest, as you can see, the most feared adverse event of this treatment were not significantly increased with respect to placebo, volume depletion, renal adverse events, fractures, amputation, or major hypoglycemia. No significant difference with respect to placebo. Now we have to say that for dapagliflozin there are clear results, but there is a confirmation for another drug of the same class, empagliflozin. This is the result reported in a press release, but the result of this study favorable for empagliflozin again in patients with heart failure, reduced ejection fraction, with or without diabetes. The results are presented at the ESC Virtual Congress 2020 this week. Going to the other drug, vericiguat, the Victoria study was published just a few months ago. In this trial, patients with chronic heart failure, reduced ejection fraction, and treated at the best of the guideline-based therapies, but there was another interesting inclusion criteria, the fact that the patients were or recently admitted for heart failure or recently treated with an intravenous diuretic or with very elevated level or natriuretic peptide, BNP or NT-proBNP. So in this trial, not only patients with reduced ejection fraction and treated with the optimal treatment were randomized, but the patient should be also more severe due to a recent hospitalization or a very elevated levels of natriuretic peptides. And the results are reported here. Here, the primary composite endpoint was cardiovascular death and heart failure hospitalization. And as you can see, the patient allocated to vericiguat showed a 10% less occurrence of the primary endpoint with respect to placebo. The difference was statistically significant, and also in absolute terms, the reduction was clinically relevant, 4.2 cases out of 100 patients per year. Looking at the other secondary endpoint, all cause death and first heart failure hospitalization, there was a reduction of 10%, statistically significant. And with respect to the expected adverse reaction, the situation was very reassuring. Symptomatic hypotension was not statistically different from placebo, and the same was true for the episodes of syncope. We have not yet the result for a new drug, another new drug, that is omecamtiv mecarbil, that is tested in a large-scale trial called Galactic HF, and the result will be likely available by the end of the year. Probably, if the result will be favorable also for omecamtiv mecarbil, we will have another drug to be added to the new drugs and the traditional drugs for the treatment of patients with heart failure and reduced ejection fraction. So in clinical practice now, we have to use a blocker of the renin-angiotensin system, either an ACE or an ARB or an ARNI, beta blockers, MRA, and in selected patients, ivabradine. And we are waiting for the regulatory approvals for SGLT2 inhibitors and vericiguat. And of course, we are waiting for an update of the ESC guidelines. The expectation is to have the new ESC guidelines for the future Congress of the Heart Failure Association in May 2021 in Florence. If both situation will be in some way accomplished, we should be able to add to the recommended treatment of today also dapagliflozin or empagliflozin and vericiguat, specifically in patients more severe, such as those recently admitted. For omecamtiv mecarbil, of course, there is still a question mark because we need to wait for the final results of the Galactic HF trial. If we move to the pharmacological treatment of the patient with chronic heart failure and preserved ejection fraction, we know that up to now, the key mortality morbidity trials were neutral. Using ARBs, angiotensin receptor blockers, or an ACE inhibitor, or a mineralocorticoid antagonist, the results were in all cases neutral. More recently, we had the results of the Paragon HF trial that tested again sacubitril valsartan, but in patients with preserved ejection fraction. The final result of the study are reported here. A patient with sacubitril valsartan showed a 13% less occurrence of the combined endpoint of cardiovascular death, and in this case, total heart failure hospitalization, but this difference did not reach the conventional level of statistical significance. It was very close to the statistical significance, but not completely significant. If you look at the two components of the combined endpoint, in terms of hospitalization for heart failure, there was a clear effect, a reduction of 15%. Also in this case, the level of statistical significance was not reached, while the Kaplan-Meier curve for cardiovascular death were completely overlapping. It was very interesting to see the subgroup analysis of this trial, and for two subgroups, there was an heterogeneity test that was statistically significant. There was a difference in terms of sex. Female gender seemed to be more favorably affected by the treatment of sacubitril valsartan with respect to males, but this evidence should be the matter of additional research in order to understand if, as sometimes can happen, to have a play or chance result when you have a subgroup analysis, or if the difference has a very biological plausibility. And the other subgroup was a subgroup perform splitting the population above and below the median of the ejection fraction. The result was very favorable for the patient under the median ejection fraction, that was 57 in the trial, while there was no difference in the patient with an ejection fraction higher than 57. So what we can say is very logical, in the sense that if even in the context of preserved ejection fraction, the ejection fraction is under the median value of the trial, the result is favorable. That goes on the same direction, on the same line of the paradigm. So probably in the future, it will be possible to treat with sacubitril valsartan not only patients with an ejection fraction under 40, but probably with a higher level. I don't know if the regulatory authorities will approve 57, but I think that up to 50 or 55, it will be possible to use this drug. And finally, the new treatments for comorbidities. Just a few words regarding comorbidities. With respect to hyperkalemia, there are two new potassium binders, called the one patiromer and the other zirconium cyclosilicate. These drugs are very effective to treat hyperkalemia when hyperkalemia occurs in patients with heart failure, but we are still waiting data for a long-term treatment to look if this drug, even used in a long-term period, have the same beneficial profile of efficacy and safety. In this case, it will be possible to treat the patient at risk to develop hyperkalemia with this kind of drugs without discontinuing the renin-angiotensin-aldosterone blockers. With respect to iron deficiency, the ESC guidelines suggest to use IV iron carboxymaltose. I have to say that the data on surrogate endpoint are very encouraging, but we are still waiting for data on clinical events. With respect to atrial fibrillation, there is the open question of ablation. There are, as you know, probably two trials. One conducted in Europe, very favorable, the Castle HF trial, and another conducted in US, the Cabana trial, not so favorable. So the role of ablation in patients with atrial fibrillation and heart failure is not yet completely defined. So we should wait for definite data on clinical events on this kind of invasive procedure. And final, valve diseases. Mitral clip, infarctional mitral regurgitation. Again, there are two trials with different opposite result. It is necessary to wait for definite data. Another trial is ongoing. And finally, TriClip, that is a tool, a device to treat tricuspid insufficiency, and it is a relatively new procedure, and there are not yet data on clinical events. So in conclusion, dear colleagues, for patients with heart failure and reduced ejection fraction, there are great news. There are other positive results with SGLT2 inhibitors with vericiguat, and other drugs should be added to the current treatment for this patient. Of course, the adherence of doctors and patients is a challenge today, and it will be a challenge also in the future due to the additional number of drugs to be used in this context. With respect to the patient with heart failure and preserved ejection fraction, there are relatively bad news. We have another neutral trial with sacubitril valsartan, but with some evidences that we can increase the number of patients to be treated with this drug with a higher level of ejection fraction with respect to the result of paradigm. And in my opinion, in the future, also research should be modified in this patient, and research should be focused more on the different phenotypes of patients that are very heterogeneous in patients with preserved ejection fraction. The recent evidences on amyloidosis are a good example on how to proceed in this field. And finally, the comorbidities. There are new interesting hypotheses of treatment. And of course, we have to wait for the final confirmation on the clinical efficacy of this drug on event reduction. Thank you very much for your kind attention. We cannot hear anything.
Не слышу? Почему? Can you hear me?
Yes, we can hear now. But before...
Хорошо. Мы немножко выбиваемся по времени, но есть все-таки к вам короткий вопрос.
Надо сначала...
Поблагодарить? Еще раз. Благодарим вас за... Вы переведите то, что я сказал, переводчик наш, за исчерпывающий доклад по лечению сердечной недостаточности на современном этапе, как действующим подходом, так и в ближайших перспективах. А у нас переводчик пропал.
We have some technical issues. We had some technical problems. Professor Ежов told that we are very grateful for this comprehensive presentation.
Нет, давайте тогда мы будем... Вы не переводите нас с английского на русский. Thank you very much for your outstanding lecture and the comprehensive review of all approaches to the treatment of heart failure in contemporary era. And I have a short question for you. I know that there are no specially planned studies, but what do you think about using ivabradine in atrial fibrillation patients with heart failure?
But theoretically, ivabradine works on IF on the IF channel. So theoretically, they should work just on the sinus node, and so just in patient in sinus rhythm. I don't think basing the hypothesis on the mechanism of action that ivabradine can work favorably in patient with atrial fibrillation, also because the drug does not work on the node. So my idea is that it is difficult that ivabradine can work in patients with atrial fibrillation. On the contrary, in the trial testing ivabradine in secondary prevention, the rate of patients with atrial fibrillation increased. It was significantly more frequent, the new occurrence of atrial fibrillation in patients treated with ivabradine with respect to those treated with placebo. And this can be due to the fact that the reducing heart rate, the possibility to atrial fibrillation to develop was more probable. So I think that ivabradine can produce atrial fibrillation and not treat atrial fibrillation.
Thank you very much. Thank you very much once again for the participation in our conference and this excellent lecture. Let's move on. Next talk will be done by Professor Thomas Ellison from Mayo Clinic, Rochester. He's director of cardiopulmonary exercise laboratory and sports cardiology clinic. And the title is Role of Cardiopulmonary Exercise Testing in Establishing Prognosis in Heart Failure.
Good morning. I'm going to talk to you today about the role of cardiopulmonary exercise testing in establishing prognosis in heart failure. Now, sort of the other end of the spectrum from my prior talk, Beyond the Bruise Protocol, which focused on athletes, many of whom have high exercise tolerance. Heart failure patients generally have poor exercise tolerance. Now, here I show you the original treadmill setup with measurement of oxygen consumption. See, cardiopulmonary exercise testing was the first form of exercise testing. Standard ECG stress testing developed later. Now, here's our current laboratory showing a patient being tested on a recumbent cycle, which we use for some of our older and obese patients. Hallmark symptoms in heart failure include exercise intolerance and dyspnea on exertion, both of which can be evaluated by an exercise test. Clinical indications for cardiopulmonary exercise testing include established advanced cardiac or pulmonary disease, grade the severity of the disease, with prognostic information, and prioritize patients for heart transplantation or mechanical circulatory support. The 2016 ESC guidelines for heart failure and suggest that exercise testing, in this case cardiopulmonary exercise testing, is recommended for the evaluation of heart transplant or mechanical circulatory support. That's class 1 indication. Cardiopulmonary exercise testing should be considered to optimize exercise prescription and to identify the cause of unexplained dyspnea. And those are class 2A indications. And finally, it may be considered to detect reversible myocardial ischemia, class 2B indication. Guidelines published in the European Heart Journal for the management of heart failure in grown-up congenital heart disease, or what we would call adult congenital heart disease here in the US. Cardiopulmonary exercise testing plays a role in evaluating symptomatic patients with normal ventricular function or asymptomatic patients with abnormal ventricular function. And they recommend looking for a 25% decrease compared to prior test, a peak VO2 of less than 15, periodic breathing, and an elevated VEV-CO2. Guidelines have also been published for the interpretation of cardiopulmonary exercise testing and standard exercise testing in the setting of heart failure. Now, I've broken this slide down into its components. We're not going to try to read all of the small print, but I just wanted to give you a general picture here that there are interpretive schema that utilize 4 or 5 variables from both the cardiopulmonary test and the standard exercise test. The exercise physiology of the heart and lungs can be measured by cardiopulmonary exercise testing. In heart failure, we generally see reduced peak VO2, reduced oxygen pulse, an elevated VEV-CO2, or a low peak end tidal CO2. And as I'll show you, those are more or less mirror images of the same thing. Exercise oscillatory ventilation, sometimes called periodic breathing. And then I'll briefly mention the respiratory exchange ratio and the oxygen saturation, as they help us understand the of concern. It's a surrogate for cardiac output, and by the way, functional capacity based on a standard exercise test is a surrogate for peak VO2. You can see here that peak exercise leg blood flow parallels oxygen consumption, and peak exercise cardiac output parallels oxygen consumption very nicely. Heart failure can be classified according to VO2. 5 classes here proposed by Weber. Class A, a VO2 greater than 20. Mild to moderate, 16 to 20. Moderate to severe, 10 to 15 mLs per kg per minute. Less than 10 is severe, and we occasionally do see patients with a peak VO2 of less than 6, but that's extremely rare. Peak VO2 has prognostic significance. Values here, we're showing a peak VO2 of greater than 14, 10 to 14, and less than 10 in terms of 3-year survival. And here we have peak VO2 in percents. 50% are predicted, 35 to 50% are predicted, and less than 35% are predicted. So high risk cutoff, intermediate risk cutoff. Oxygen pulse is a surrogate for stroke volume. It's the peak VO2 divided by heart rate. Why do we use the oxygen pulse? Well, obesity and reduced peak heart rate on beta blocker will both reduce peak VO2. But the oxygen pulse is expressed in units of mLs per heartbeat, so it's neither influenced in a negative way by the weight or by the heart rate. And here's a study published showing that a peak VO2 of less than 10 in obese persons or less than 14 in normal weight persons provides a measure of event-free survival. In addition to just the peak value for VO2 and oxygen pulse, we like to see whether it goes up continuously or whether it plateaus prematurely during the test. The same with the O2 pulse. A number of papers, including one from my lab at Mayo, have been published on this subject. A very powerful measure, perhaps even more powerful than O2, for establishing prognosis in heart failure is ventilatory efficiency. Now, this is measured as the VE, expired ventilation, to VCO2 slope or ratio. When we measure the slope, Weber has developed 4 ventilatory classes, with normal slope being less than 30 and class 4 being a slope greater than 45. Age does play a small factor here, so we have to be a little bit careful in terms of risk stratification in the oldest and the youngest patients by this method. VE-VCO2 is the ratio of airflow in the lungs, which can be affected by lung diseases or volitional hyperventilation, and blood flow to the lungs. So the CO2 comes largely from the blood. There's very little in the inspired air. Reduced cardiac output, right to left shunts, and pulmonary emboli can all greatly reduce the amount of CO2 coming to the lungs. In between, we have gas transfer from the lungs to blood and from the blood to lungs, a thickened alveolar membrane, as often occurs after chronic heart failure, interstitial lung disease, and pulmonary edema, including pulmonary edema caused by high left ventricular filling pressures, can interfere with gas exchange in the lungs. Using a cut point of 34 for the VEV-CO2 slope, that's a common cut point used, we can see that cardiac-related hospitalizations and cardiac-related mortality are both strongly related to a high versus normal VEV-CO2 slope. The VEV-CO2 slope is one of the few exercise variables that has been validated both in systolic heart failure, or what we now call HFrEF, and diastolic heart failure, or HFpEF. The pressure of end-tidal CO2 is basically the partial pressure of CO2 at the end of the expiration of air in a single tidal volume. ARENA in 2 studies showed that resting values less than 33 have approximately the same significance as New York Heart Association class 3-4 versus 1-2, or an EF less than or greater than 25%. Looking at the highest highest end-tidal CO2, which generally occurs around the anaerobic threshold, or where we're seeing the nadir of the VEV-CO2, predicts increased mortality. So a resting value less than 33 or a peak value of less than 36. Here's where I mentioned that end-tidal CO2 and VEV-CO2 are basically mirror images of each other. So here are 2 exercise tests. On the right, a 35-year-old man with heart failure from treatment of his Hodgkin's lymphoma is well compensated. He has a normal end-tidal CO2 here of about 42 with exercise, and you can see the shape of the curve. And here is the VEV-CO2, which has the opposite shape, and it's normal down in the range of about 28 with exercise. A 39-year-old man with a univentricular heart being listed for transplant has a much lower end-tidal CO2 and a much higher VEV-CO2. And again, the shapes of those curves, we're looking at the green line here and the blue line here, the shapes of those curves are almost exact mirror images of each other. Periodic breathing. So a 67-year-old woman with severe left-sided heart failure and grade 4 out of 4 diastolic dysfunction. She has an EF of 15% and a right ventricular systolic pressure of 74. You can see her tidal volumes and respiratory rates are going up and down together. This isn't volitional hyperventilation, where the patient is alternatively panting with a high respiratory rate, low tidal volume, and then breathing normally. Cheyne-Stokes breathing is the term used when this occurs at rest. Periodic breathing, or sometimes called exercise oscillatory ventilation. So you can see when it's present, survival is much diminished over when it's not present. I should mention this variable is seldom seen. It's not something we regularly notice on exercise tests. It's pretty rare and confined to the most severe cases. So if we go back to the guidelines presented by Guzik et al., we can see that presence of EOV is considered a high-risk finding, as is a resting end tidal CO2 of less than 33, or case of exercise. Respiratory exchange ratio is just a measure of effort. It's the VCO2 divided by the VO2. Aerobic metabolism from glucose and fat will give you a respiratory exchange ratio of 1, but the buffering of lactic acid produces more CO2 and will increase the respiratory exchange ratio. And finally, severely reduced diffusing capacity and left to right shunts, primarily intracardiac, but sometimes intrapulmonary, can result in arterial desaturation. Before I show you our case and interpret the exercise test in the case, let's just remind ourselves that standard exercise test variables, including hemodynamics, the electrocardiogram, heart rate recovery, and symptoms, are also prognostic in heart failure. We want to see the pressure rise, not fall. We don't want to see patients limited by ECG changes. Heart rate recovery should be greater than 12, and symptoms of dyspnea are high risk and angina intermediate risk. So let me finish with a brief case. This is a 39-year-old man, BMI of 27.5. He exercises for 7.2 minutes or 7.2 METs on our protocol, 57% of predicted. Now that's not very good, but in the setting of heart failure, that would still be considered low risk. His heart rate increases to 82%. He's of course on beta blockade. He has a mildly abnormal heart rate recovery. His systolic blood pressure is relatively flat. It doesn't decrease, but it doesn't increase much either. He has a left bundle branch block and a few PVCs, which place him in intermediate risk. The reason for termination is fatigue and dyspnea, which is a high-risk situation. And there's his exercise ECG with a somewhat narrow and unusual-looking left bundle. In terms of cardiopulmonary test results, peak VO2, 14.4, 35% are predicted for this young man. That puts him in Weber's functional class C, and he's high risk by both the absolute number and the percent predicted. He gave us a good effort on the test with a peak respiratory exchange ratio of 1.129. And you see the VO2, there's predicted, there's actual. It not only is very low, but it plateaus near the end of the test. The oxygen pulse similarly is quite low and plateaus at the end of the test. No oscillatory breathing pattern. The nadir of the VE/VCO2 is 40 and the slope is 45. Using Weber's classifications, that puts him at high risk. His end tidal CO2 starts at 27 and ends at 30. That's a high-risk finding. And an additional finding here is that he drops his oxygen saturation from 91 to 84% during the test. So by now you may have guessed that this is a pretty unusual heart failure patient, or not, at least not the normal one. We'll see. So the standard test gives us 2 high-risk findings and 2 intermediate risk findings. We have additional high-risk findings of a high VE/VCO2, a low end tidal CO2, a low peak VO2, a low O2 pulse, and arterial desaturation. So who is this patient? Well, complex single ventricle heterotaxy syndrome. He has a common ventricular enlargement and an estimated ejection fraction of 25%. He underwent successful heart transplant 8 months after the exercise test. Fortunately, liver transplant was not required. Conclusions? Cardiopulmonary exercise testing is useful in the evaluation of patients with documented heart failure and individuals with symptoms that might be due to heart failure. It's valuable for diagnosis, risk stratification, prognosis, and evaluation of interventions. And I will say goodbye to you with this final slide. My 3 rules of cardiology told to first-year fellows their first day in the exercise lab. The patient is a used car. The stress test is the test drive. We want them to fix the patient, not just the pictures. We want to do something for the patient, not to the patient. Thank you.
Dear Professor Ellison.
Yes, thank you.
Do you hear me? Thank you very much for your excellent and brilliant presentation, a well illustrative presentation. And there is one question from Professor Pogosova.
Tom, can you tell me how often do you use this test in heart failure patients? I mean, if this is a routine heart failure patient who came for some checkup, do you use only in case of some deterioration of the situation, or there is an algorithm? How often should you use this? Which is the Mayo standard for this frequency?
Yeah, the Mayo standard is to include this test when the patient comes for reevaluation. Very important to accurately assess their functional capacity, look for any deterioration, match that against the echocardiogram, decide whether to add or in some cases subtract medical therapy, or to move forward with listing for transplantation or implantation of LVAD. So it is part of the routine evaluation at Mayo. Patients usually come back once a year to the heart failure clinic. They're managed locally in between. So we have a large catchment area. These aren't people across the street. Okay, does that answer?
Да, вполне. Это очень важно, потому что это тяжелая группа пациентов, и важно уточнить этот момент, он действительно определяющий. И еще последний вопрос: насколько часто сейчас, в настоящее время, какой доли пациентов вы переводите?
I might also...
I'm sorry.
Она
no
не может.
connection. I'm sorry, there is no possibility to translate. I will ask in English. How often is it possible to use the how often do you usually invite patients with preserved ejection fraction? Is there any difference between those with preserved ejection fraction and those with low fraction? Are there differences in this algorithm, or all patients are invited once a year?
No difference.
No difference.
No difference. We also, as you can see, have a very large
Excellent.
population. Yeah,
Thank you.
a very large population of patients with adult congenital heart disease, with Gooch. So we have some very complex with systemic right ventricular failure, univentricular heart failure. So these patients, again, are also faulted. They're much younger. Their conditions are much more complex. Instead of combined heart-lung, there's often combined heart-liver transplantation. So it's a very interesting practice with those patients.
Спасибо. Thank you.
Excellent. Thank you very much. We have to move on. And the third talk from Dr. Zaki Attia today about artificial intelligence. Now for ECG-based screening, please.
Hello everyone, my name is Tzachi Attia. I'm a co-director of AI in cardiology in the Mayo Clinic. It's my pleasure to present to you artificial intelligence for cardiac screening and interesting cases. I want to thank again the committee. These are my disclosures. When we think about AI-enhanced ECG interpretation, we usually think of the ability to scale human ability, meaning streamlining things that humans can already do. Reading ECGs faster or more accurately, or maybe use AI as a gatekeeper before using the physician's time. In this presentation, I'm going to talk about going beyond human capabilities, trying to do things that humans cannot. The first model is for screening of heart failure or left ventricular dysfunction. As you know, 1 out of 4 deaths in the US is due to heart disease, and 1 out of 9 deaths is due to heart failure or left ventricular dysfunction. About half of the people who develop heart failure will die in 5 years. It's worse than most cancers. It also costs the nation more than $30 billion each year. In our work, we focused about systolic dysfunction, where the ejection fraction drops. As you know, ejection fraction is the most important single number for your cardiac health. A normal ejection fraction is between 50 to 70%. And the drop in EF might start with no symptoms at all. Once we detect the drop in EF, we have ways to treat it. The most common way to detect ejection fraction or calculate it is by using echocardiogram. As seen in the video, as you all know, it's a very time-consuming process. It requires detecting the volume of the ventricles during systole and diastole and calculating the ratio. The main issue with that is that about 2 to 9% of the population have left ventricular dysfunction. So current methods like echocardiogram, CT or MRI are expensive and require a physician for analysis. It's great for diagnosis, but it's not really suitable for wide population screening. There's a statement for the Heart Failure Policy Network saying that currently patients are facing a lottery for diagnosis of heart failure based on their access to these tools, especially echocardiography. When we talk about the unmet medical need, we remember that we have the electrocardiogram as well. The electrocardiogram or the ECG is a recording of the heart electrical activity. It's the sum of all the myocytes' action potential. And when we record it over the body surface, we can get a 12-lead ECG that gives us not only the rhythm, but also spatial information about the heart. We know that clinicians cannot assess ejection fraction from ECG, at least not most of them. So we asked ourselves, can an AI model do it? Maybe by showing a neural network a lot of ECG, it will understand how a normal EF looks like versus an abnormal EF1. Because, as we said, we do not know what parts of the ECG reflect an ejection fraction. It excludes us from using the conventional machine learning pipeline. In the conventional machine learning pipeline, we have a human engineer that is responsible to convert the input signals, the ECG, for example, to features. So he would meet a physician, and the physician would say, we know that QP segment is important for us, QRS width, QRS amplitude, the T-wave slope. But we don't know which features we should include or should not include. In deep learning, on the other hand, instead of using features that are described by humans, we just show the network the whole ECG. The network is responsible not only to connect these features to the results or the ejection fraction in our case, but also to find the most relevant features. It does that by applying filters that were originally designed for image processing on the ECG and extract morphological and temporal features of the ECG. This work was published in Nature Medicine about a year and a half ago, and I just want to acknowledge all of the investigators working with me. We started with 600,000 patients, and after a lot of data cleaning, we got to 100,000 patients with an ECG and echo 2 weeks apart. We used about half of the data to train the network and another half to test it. We used a convolutional neural network. This type of neural network was originally designed to process images, but we adapted it to process ECG matrices. We asked the network to differentiate between patients with ejection fraction of 35 or less and patients with above 35%. We used the ROC curve and the area under the curve to assess how well the model worked. An ROC of 0.5 is a random test, and an ROC of 1 is a perfect test. But most screening tests are in the range of 0.7 to 0.9, for example, cervical cytology or PSA. The ROC for the detection of low ejection fraction was 0.93, so superior to most screening tests, and worked with a sensitivity and specificity of 86%. When we look at the results of the AI model, you can see that patients that were screened as positive, meaning we would send them to do an echocardiogram, about 1/3 of them actually had an ejection fraction of 35 or less. 30% had an ejection fraction of 35% to 50, meaning it was low and still useful to know. But there was another third of the patient that had an ejection fraction of 50 or above, so a cardiologist would deem them as normal. When we try to compare patients with positive, meaning abnormal ECG and normal echo, true negatives, meaning patients with normal ECG and normal echo, we saw that if you look at the future, patients with abnormal ECG have 5 times the risk of developing low ejection fraction in the future. So in essence, the model was predicting what's going to happen based on subclinical features. That leads us to our first case, sudden death in the family. A 35-year-old male presents after his sister dies suddenly. He gets an ECG. The cardiologist look at it and say, it's a normal sinus rhythm, normal ECG. But the AI thinks it's having low ejection fraction. Same patient got an echo. Ejection fraction is actually 18% due to dilated cardiomyopathy that was familial. He's now currently waiting for a transplant and just shows us how the AI was able to detect the disease even though the ECG looks normal. We then tried to improve the EF model. The first attempt was using age and sex because we know both age and sex are contributors to cardiac disease. But then when we tried to add into the model, it did not improve. It did nothing. The other option was that the model is already knowing if you're looking at a man or woman and what's the age. So even if it doesn't know it's a man or woman, it just sees it has 2 groups of patients, 2 phenotypes. To test this, we try to assess what's the patient age and sex just based on the ECG. By building a neural network that takes an ECG and outputs the age and sex of the patients, we were able to test the hypothesis. As you can see here, the AI was able to detect the ECG age with very, very high accuracy, and it was almost a perfect test for the detection of the patient sex with an AUC of 0.97. But we did notice that some patients look really older than their actual age, while some patients look really younger versus their actual age. So we looked at few patients, and that led us to our next case. This is a case of a patient that had multiple ECGs over the years. This is his ECG age versus his real age. As you can see, when he was 30, he looked like he's 50. When he was 50, he already looks like he's 70. But then suddenly something happens. We find a fountain of youth and become young again. So we try to understand what happened here. The reason is that he got a young heart. He had a heart transplant, his cardiac health improved, and he now looks younger. So while we don't recommend it as an anti-aging technique, we just think that the AI ability to detect cardiac age is very useful in determining the quality of patients. The third model we're going to talk about is the detection of hypertrophic cardiomyopathy, a genetic disease that can cause sudden death due to excess heart muscle. We use our HCM clinic dataset to find all the patients that we have ECGs, and we know that they have hypertrophic cardiomyopathy, and match them with controls that we know for sure that does not have the disease. We created a neural network to differentiate the two. And again, the AUC here was almost perfect. In the testing set. In our third case, we're going to discuss a 25-year-old woman with known hypertrophic cardiomyopathy. As you can see here, her ECG is very, very normal. Yet, the AI HCM algorithm detects she actually have HCM. But this was known. The interesting part happens when she gets a myectomy. Now, by removing the excess muscle, the ECG looks much more abnormal. Yet now the AI thinks that she only has 2.5% chance of having HCM. So while the ECG is abnormal, still the AI is able to focus only on the HCM parts. In our fourth model, we're going to discuss the detection of aortic stenosis. We define aortic stenosis by using our guidelines and detecting patients that had moderate or severe aortic stenosis based on these measurements. Patients with normal or mild aortic stenosis were considered normal. We used about 1 million patients to start this research and ended up with 250,000 patients, half of them used for training the network and half of them used to test it. The AUC for the detection of aortic stenosis was 0.85, and similarly to the ejection fraction models, patients that had a false positive, meaning the AI thinks they have aortic stenosis, but the echo disagree, have double the chance of developing it in the future. In our fourth case, we can see a 67-year-old man presented with increasing dyspnea to the ED. He was detected as positive for the aortic stenosis by the ECG, but by that time his echo was also very, very positive. So he had a very severe case of aortic stenosis. So we looked back then in ECG and said, well, could we detect him earlier based on his earlier ECG before he actually had dyspnea? So 8 years ago, we had an ECG. But he was negative for aortic stenosis. And it makes sense that 8 years ago, he did not have the disease. But when we looked at an ECG 3 years ago, you can see that even though the ECG looks pretty normal, the AI ECG already detected as a positive aortic stenosis event. The last model we're going to discuss today is screening for paroxysmal atrial fibrillation. As you know, atrial fibrillation is often clean, sometimes asymptomatic, and it can have a major consequence, specifically stroke. And when a patient with cryptogenic strokes appear, it's very important to know if he had atrial fibrillation or not. If he did not have atrial fibrillation, we would treat him with aspirin. If he had atrial fibrillation, we would give him warfarin or other anticoagulants. And we wouldn't want to give them to patients without atrial fibrillation because studies have shown that it would increase their chance of bleeding without actual benefit. The current ways to detect if someone had AF or not is by trying to catch the AF event. So you can wear an iWatch, a cardiac device, put a sticker, but you would still need to catch the AF while it happens. Another way of doing it is by continuously recording the patient's ECG using a loop recorder in their chest. But this is very expensive and usually requires 1 or 2 years of follow-up. We tried to see if an AI can look at a patient during normal sinus rhythm. So a cardiologist would look at the ECG and say, this is a normal ECG. Maybe the AI would be able to detect the fingerprint of past AF events. So we compared patients that never had AF to ones that had AF in their past. The AUC for this test was 0.87 when using a single ECG, and when using 2 ECGs for the same patient, the AUC went up to 0.9, giving us a sensitivity and specificity of about 83%. This leads us to our last case for today. This is a patient that had her first stroke in 2015. A few months ago, she had her second stroke, and we searched for her previous ECG to detect if she might have AF in the past. As you can see, not only that she was positive, as you can see it's above the threshold here, for her 2 strokes, she was positive for AF 10 years ago. This leads us to the question of could we prevent her second stroke by treating her with anticoagulants after her first stroke? The main issue is that we don't really know if she had AF or it's just that the algorithm thinks she has AF. A few months ago, she actually had her first recorded AF event, and now we know she is an AF patient. We try to then understand what makes the AI think she has AF, but as you can see here, even though the AI ECG is positive that she has AF, it looks very, very normal. For summary, these networks have an amazing ability to see invisible signals that we can leverage to help patients. It will also change how medicine is being practiced by showing us pre-vivals, patients that we know that are going to have the disease before it's actually manifested. I want to thank you again for listening.
Thank you very much for your excellent talk, this brilliant information. Can you hear me? Мы не видим.
Yes, very well.
Yeah.
Oh, okay. So, I have one question for you. Do you use AI for ECG screening in Mayo Clinic in routine clinical practice or just for research purposes?
So that's thank you again for inviting me, but that's a great question. About a year ago, we created something we called the dashboard. Every ECG done in the Mayo Clinic is going to all of our AI models that you have seen here, all of these 5 models. For the ejection fraction, we are currently in FDA approval processes, but we are allowed to use it internally in Mayo, meaning the physician can see if the patient have higher chance of having low ejection fraction. It sees it in the EMR, in the report, when he looks at the patient clinic and can send him to an echo. So it is being used, but only for Mayo patients internally.
Thank you very much. It's clear, absolutely clear.
I'm sorry, I also want to say a few words. I think it was a very impressive session because all presentations were very different, but very interesting, each one from its point of view. I think these presentations enlarged our knowledge and our possibilities to diagnose, treat, and rehabilitate our patients. Absolutely new view on the inflammation processes and connection of inflammation with cardiovascular diseases. We know the inflammatory theory of the atherosclerosis. It is connected with our scientist Anichkov and other scientists, and now more and more knowledge, more and more evidence in this regard, and also this link between parodontosis and cardiac diseases is time to time coming to light, and it is really impressive. Thank you very much, Professor Guzik, for this presentation. I want to say also many thanks to Aldo. So interesting presentation on and comprehensive view on all aspects of heart failure and treatment of our patients. Heart failure treatment is now going on top because new drugs, new possibilities, even from endocrinologists came to light, and it is really it increases our possibilities to treat our patients using these new ways of treatment. And also, I don't see Tom. Probably he has some disconnection, but anyway, Zahi, please say my words of gratitude to Tom Allison, who is very experienced and great specialist in functional investigations and comprehensive study of these patients. And also, of course, it is incredible what you told about artificial intelligence in the morning session and now, because it is difficult to understand for cardiologists, but it is so unusual that using routine ECG, we may know so many things about our patients, and it is cheap, and it is useful, and maybe this will give second life to ECG, and it is very important for countries with, for example, not so rich, and it is real possibility to screen and find those who need especially attention. From the organizing committee, let me say once more, thank you, and thank you for joining us from different countries, from different sites, cities, and points of world, and I hope that one day, I hope next year, you will come to Moscow and we will in person discuss these problems, because of course in-person contacts are much more interesting and much more preferable than Zoom or some other things. Thank you very much.
Thank you.
Thank you.
Thank you very much.